Well, I would like to greet everybody who's out there in TV land, as I call this. I'm an old person here. And thank you all for joining in this evening. I'm Mary Jane Minkin. I'm an obstetrician gynecologist, and I do have a special interest in menopausal health. But that's just one of many areas that I'm interested in. And I got very interested in the issues involved with a very special group of patients. For cancer survivors. And I just want to briefly summarize how I got involved in what I do now. And it also brings in, I'd like to do a little tribute to a very, very important person who passed away a couple of days ago. And this is to my mentor, Dr. Peter Schwartz. And I used to have residents coming over to my office to learn how to take care of menopausal patients. And about 2007, thereabouts, one of the chief residents, a very fine young woman named Dr. Elena Ratner, spent a few days with me in my office and said, after a few days, she said, Mary Jane, you see a lot of cancer survivors. And I said, yes, I'm very sorry they had cancer, but I'm sure glad they're surviving. And she, at that point, had already committed to doing a GYN oncology fellowship under the direction of Dr. Schwartz. And she went to Dr. Schwartz and said, we need to take care of these folks as part of gynecological oncology. And he said, yeah. I said, so she said, we'd like to have a dedicated time in the clinic, in GYN cancer clinic, GYN oncology, to see these women with menopausal sexual and intimacy issues. And he said, great. And we started off doing it just for gynecological oncology survivors. And we did it half day a month. And it grew. And what happened, and these were just strictly to devote to those issues. Well, other oncology patients in the institution at Yale found out that what we had as a service, and they said to their providers, they said, we ought to have this for everybody who's dealt with cancer. And so the folks tried to get together to have a meeting and multiple meetings to see if that could be implemented. But unfortunately, since the people, the internal medicine folks who aren't gynecological specialists, that they ended up saying, we don't deal a lot with this menopause and sexuality business. Could you see these folks too? So that's how Elena and I inherited everybody in the institution in oncology. And so it's been our very great pleasure to help take care of everybody dealing with any kind of cancer issues. And these are very, very important for quality of life, as I believe all of you know. So that's really, really important. And that I'm here to answer your questions. I'm going to start off with a few basic issues. I thought about slides, but I said, you don't need to get bored by slides. We'll just talk and then spend most of the time answering questions for folks. So a little bit about how we started. And I just do want to mention that, unfortunately, Dr. Schwartz passed away earlier this week. And he was an absolutely wonderful, wonderful person who was really devoted to these issues for his patients. Now, of course, he was a gynecological oncologist, but he felt very badly for folks who had any kind of cancer issues. So I want to honor his memory, and we'll always go on to honor his memory by trying to help folks dealing with these issues. And he wanted to have women to have, like men too, but that's not what he dealt with, to have really terrific quality of life after taking care of their cancers. And that's what we're here to do. Unfortunately, much of what we do in gynecology and general oncologists do as well, basically it leaves women in a menopausal state. And indeed, much therapy with gynecological cancers, of course, we end up oftentimes taking out the ovaries or taking out a uterus and taking out the ovaries with that, which does render a woman menopausal. Unfortunately, much of the chemotherapy that's administered both to GYN patients and to non-GYN patients, unfortunately, can be toxic to the ovaries. And sometimes the ovaries will wake up, but much of the time they won't, and women will be left menopausal. And of course, the other thing besides surgery and chemotherapy that can render women menopausal is also radiation therapy. And radiation therapy brings about a whole another group of issues besides just making the ovaries stop working. They basically lead women into menopause. But unfortunately, that radiation therapy can also lead to some scarring. Inadvertently, nobody tries to do it, but there are many organs in the way of the X-ray beams there. So that the radiation therapy beams, so that we can end up with a whole host of different problems. And of course, we sort of bunch these things together. There are differences between menopause menopausal issues, intimacy issues, sexual issues, but they often do go together, and we have to deal with all of them. And the one thing I'll put in a plug for our Sexuality, Intimacy, and Menopause program is that it is run basically by me, and of course, Dr. Ratner, who is, again, the head of clinical GYN oncology, and she takes care of a lot of people who have other than GYN malignancy issues. And we have the world's most wonderful physician's associate, and that's Joanna Daddario, who sort of is the heart of the program and runs everything every day, and is really a superb clinician and coordinator. We're the GYN type folks and the medical folks. We also have, and we started this at day one of our program, we have input from psychology, our behavioral health team, and we have several psychology fellows who work with us closely in the clinic, and basically all of our patients get seen by somebody from behavioral health as well, because obviously carrying a diagnosis of cancer has many, many psychological issues involved with it, and particularly when we start talking about issues related to sexuality, intimacy, and menopause for cancer survivors, there are many, many emotional issues that can be helped. And so we work closely with our behavioral health team, and we all work together to help try to take care of folks. So that's basically the basics of the program here. We already had one question, and I don't know whether we want to start by asking questions and spending time devoted to the questions people have, versus me going on as far as different issues that we face on a regular basis. Should we start with the one question that I know is in the chat here? Okay. Let's see. Let's see if I can get the chat here. Okay. All righty. Let's see what we got here. I know we had a message before. Eliza, can I ask for help? Am I doing something wrong as far as not seeing the question that I know that we had to start out with? Okay, here we go. This is a question. Okay. First question that folks had. Okay. And we could probably spend about the next hour on this question. So please ask your other questions if people have. But we'll start with this question, which is extremely commonly asked. Okay. There seems to be a growing body of evidence that indicates that vaginal estrogen use is safe even for those who have had a history of estrogen receptor positive cancers. Can I comment on this? Yeah, we can comment for quite a long time. Okay. Part of the issue, and so this gives me a chance to go over to the questions involved with estrogen therapy. And some of you, there's been a huge amount of chatter out in the media, and this has to do with non-cancer patients as well, is just the use of estrogen therapy in people who don't have a history of cancer, as far as does it lead to an increased risk of cancer? Okay. And the answer is that there was a study that was published in 2002 in July, not that I remember the date, July 9th to be precise. And this was basically a study called the Women's Health Initiative. And the Women's Health Initiative was basically designed to say, does estrogen therapy help prevent heart disease? That's what the study was designed to do. It was not designed to comment on cancer incidence. However, one of the downside risks that people had known for quite a while was the fact that there may be some link people thought about with estrogen and breast cancer. After all, there are estrogen receptors in breast tissue. Maybe estrogen might cause it, et cetera, et cetera, et cetera. And so the study that was done, basically the study was done to see if estrogen does prevent heart disease. But as a downside, they said, well, does it increase the risk of breast cancer? And this was a prospective randomized double-blind study. So only people not involved in the study would know who was getting what. Okay. And what they saw, they thought, was that women who took estrogen, who had a uterus in place, okay, and when a woman has a uterus in place and takes estrogen for menopausal management, she needs to be given some progestin with it to protect the lining of the uterus from developing cancer de novo, as a spontaneous cancer. And so what they saw in this study, okay, because they also did a study of women who had had a hysterectomy, and if you've had a hysterectomy, for systemic estrogen therapy, you do not need to take any progesterone to protect the lining of the uterus because there's no uterus there. So that makes it easy. And so they had two parallel groups. They had a group of women who did not take progesterone because they didn't have a uterus, and they had a group of women who took estrogen plus progesterone because they did have a uterus. And it was in that group of the women plus a synthetic progestin that they showed a very, very, very slight increased risk of breast cancer. Okay, that's what the WHI showed. And then there were further studies which confirmed, yeah, very, very, very slight increased risk. Now, the one thing that I can tell you is that the women who were in what we call the estrogen only group, women who just took estrogen and did not take any progestins with it, okay, had no increased risk of breast cancer. Okay, so what happened though is the FDA, so I've got to implicate the FDA here, said, well, we are going to put a warning on every estrogenic product, whether it's with progestin or not, whether it's used systemically, in other words, whether it's a pill or just whether it's in the vagina. We're going to put a warning in saying estrogen therapy is associated with breast cancer. So if you go to your pharmacy and you pick up a tube of vaginal estrogen for vaginal dryness, okay, that package insert that comes with the box says you are putting yourself at increased risk of getting breast cancer from using vaginal estrogen. So what happened is that scared the dickens out of everybody, and women got scared away from taking estrogen vaginally, although there was really never any data that showed any increased risk of getting breast cancer from using vaginal estrogens. However, this whole mythology got about that, oh, it's dangerous, particularly for a woman who has had breast cancer, to use vaginal estrogen because of an increased risk of recurrence. Okay. There is really minuscule data to show that. And now there have been a couple of recent papers showing a very, very, very slight increased risk. Most of the literature does not show an increased risk. And what I can tell you is both the American College of Obstetricians and Gynecologists and the what's now called the Menopause Society, the North American Menopause Society, have put out position statements, papers with them showing the data that there is no increased risk of breast cancer with vaginal estrogen therapy. However, many people, of course, they still get the boxed warning, and the boxed warning says the same thing. So what happens is when I'm doing counseling for a patient, okay, I discuss the pros and the cons, things like that. And I'll say, but really there's no data. The American College of OBGYN says it's safe, et cetera. But what'll happen is they'll go home, and the husband or whatever, will pick up the paper and say, oh no, dear, I don't want you to have any increased risk of cancer. It's not worth us having sex for you to use vaginal estrogen. And the partner says you can't use vaginal estrogen. I've seen this on very many occasions. So, and also the oncologists, some of them do get nervous about vaginal estrogens. And, obviously to a group of cancer survivors, I'm not going to diss oncologists. Or obviously, you respect your oncologist. And if your oncologist is having any concerns, they probably will not encourage you to use any vaginal estrogens. Now, the good news is, that there are many therapies for vaginal dryness, which leads to uncomfortable issues with sex, and can also lead to urinary tract infections, which is another problem that women often will get when the vagina is dry after menopause, whatever the cause of the menopause was. That there are very many moisturizers and lubricants, and we'll talk about the difference between the two, which do not have estrogen in there. Okay. And one of the very commonly used products, and let me back up and say the difference between a moisturizer and a lubricant, because many women do not know the difference. A moisturizer is a cream or a gel that you put in the vagina 2 to 3 times a week in general on a regular basis. Sex, no sex, sexually active, not sexually active, just to keep the vagina moisturized. And there are plenty of these that do not contain estrogen. One of the most popular varieties right now is actually a product called Reverie, is the trade name of it. And that has, ladies who put hyaluronic acid on their face. Well, this is hyaluronic acid for the vagina. And it works very well for a lot of people. And they use it regularly. And again, it's usually it's a suppository. You get it online, and you pop it in the vagina 2 to 3 times a week. And it's usually quite effective. Now, you can use it more than 2 to 3 times a week. I have some people who use it 4 or 5 times a week, and that's fine. It's perfectly safe to use. And they like it a lot. The other thing is that there are other suppositories in there. Oh, one other thing on the Reverie, there is a generic version that is made. I believe CVS carries a generic hyaluronic acid variety, but it's often not stocked. So anyways, you can check to see it. It's a little cheaper than getting the stuff online from the Reverie folks, but as I said, CVS has been making it intermittently. There are other products too. For example, another very commonly used non-hormonal product for vaginal dryness is something called Replens, Replens. That's a gel, and it comes in an applicator that you just use a little plunger. This is what it comes with. You plunge it up inside into the vagina 2 to 3 times a week, and it keeps the vagina moist. Now, many women will still like to use a lubricant at the time of sex. Okay, very helpful. And that there are many, many, many brands out there, probably well over 100 brands, I would say at the moment. You can get them at the pharmacy, you can get them online. And again, no prescription is necessary. These are non-hormonal. Okay, and they are very common and very, very safe to use. But if they don't work for you, that you can discuss with your oncologist to saying, do you feel I'm okay to go ahead with using estrogen? And that we will be happy to prescribe it if you'd like to use it, because the data, I think, is pretty supportive of the fact that it does not increase the risk. Now, there is one other product that I want to be complete and mention to you all, okay? There is one product strictly for vaginal dryness that is not estrogen, okay? It is a hormone, but it's not estrogen. And this medication is very rarely used. I don't know why not. It's a good medication. It's a pill. And some people, hey, don't like messing around with vaginal stuff. They find it messy. They find it annoying, things like that. So what this medication is called Osphena, Osphena. It is a pill that you take with food. It's much better absorbed if you take it on a full stomach, so take it at dinner time. It's once a day. And you know what drug this is very familiar to some of you? That this is a sister drug of tamoxifen. The full name of this drug, Osphena, is ospemifene, and it is what is called a SERM. And it's an interesting molecule. And unlike many SERMs that bind to vaginal tissue, which is what SERMs do, they bind to estrogen receptors. This particular SERM happens to turn on the estrogen receptor, just like SERMs all bind to bone and they turn on the bone and they help prevent osteoporosis. So this particular SERM, yeah, it helps prevent osteoporosis. It does that too, but it's also really good for the vagina. Now, you would not take ospemifene with tamoxifen because you don't take 2 SERMs at once. And you wouldn't take it with something like an aromatase inhibitor, okay, like letrozole or something like that. But once you finish that initial therapy, it is perfectly fine to take it. And it's a good drug, and it's good. And nobody's going to yell at you for taking estrogen because it's not estrogen. It's actually an estrogen blocker, just like tamoxifen is. So that's out there, underused, and it's out there, okay? Questions on that before we go to the next question? Okay. Next question we have here. Intimacy is difficult. 65-year-old finishing breast cancer treatment help. Well, I hope I can help. And I'm sorry to hear that the intimacy is difficult. We know there are these problems, but let's go back to that first question if we can, okay, and say we have plenty of options, things like that are non-hormonal, okay, and your oncologist may be okay with a hormonal medication if the non-hormonals don't work, but we have other tricks, okay, we really do, okay, and one trick that I'm going to suggest, and some of you, I hope I'm not offending anybody. I mean, I offend a lot of people, but I don't mean to. But anyway, but vibrators are very good for folks to have. And I will quote one of my good friends who also takes care of a lot of cancer survivors. My friend's name is Lauren Stryker, and she's out in Chicago. And she says, you never ask a patient which vibrator they have. Excuse me, whether they have a vibrator. Never ask a patient whether they have a vibrator. The answer should always be yes. And the only question you can ask is, which vibrator do you have? Okay. And vibrators, besides being fun and making people have fun, are also therapeutic. That vibrators, by using a vibrator, it increases pelvic blood flow. anything that increases pelvic blood flow is good for moisture, okay, and it's fun, okay, so we like this. And one of the things that we find is, and our favorite site, and I don't own any stock in this, but I like the site, it's called Medamour, Medamour, medamour.com, and as the name implies, it's run by a group of medical folks, doctors, nurse practitioners, PAs, who sort of vet the individual products on the site, and being the nerds that they are, they write little descriptors on there so you know what you're getting. And so they have all sorts of different vibrators on there. And you may say, oh, that looks cool or that looks cool. Go through it with your partner. She or he can, maybe enjoy things with you as far as thinking about this. And it may look like fun for you. And it's therapeutic for increasing pelvic blood flow. On that site, they also have things like arousal creams and stuff, whether they work or not, I don't know, but some people find them to be fun. So that's a good thing to do. So those are another option that people can use. Okay. And there are other things that one can do also. There's another product out there, which I think is good. Okay. And what it does is to increase pelvic blood flow, like the vibrator does, okay? And this product is called Ristela, Ristela, and it happens to be made by the folks that made the Reverie hyaluronic acid for the vagina. And this is an herbal product. This does not require a prescription. It is totally non-hormonal. Anything that you can get over the counter doesn't have hormones in it. And what it is, it's an interesting compound, I think. It's imported from Europe. It started there. And it has a couple of amino acids in it, arginine and citrulline, but it also has something called pycnogenol in it. Now, for those of you who are into naturopathic type stuff, pycnogenol is very, very big in the naturopathy world. It's from the French maritime pine bark. And what it does is it is what's called a nitric oxide synthase product, that it causes the amino acids to get made into nitric oxide, NO. And what nitric oxide does is that it helps dilate pelvic blood vessels, so you get more blood flow. And the theory, and of course, blood flow translates to more fluid, to more moisture, which is always good, but also it translates into mental things as far as, gee, your brain says, oh, there's much more blood flow in my pelvis. Maybe I should go and do something about it, get a little more active, have some sex. And that's a good thing. So anyway, so that's another option that you have, which is totally non-hormonal. And again, a vibrator is good, totally non-hormonal, increases pelvic blood flow. Ristela increases pelvic blood flow. And again, now, if you look at the European data on Ristela, they say they have like a 70 to 80% success rate with increasing libido. We don't find anywhere near a 70 to 80% success rate, but I'd say we get 40, 50% of women who say it helps their libido, and that's a good thing too. Okay. So these are things that are very easy to institute, and people aren't going to get upset with saying, oh, that's a dangerous thing or anything like that to do. Now, one thing that I do want to mention here, because we talk about this a lot in our clinic, okay, is that if you haven't had sex for a while, and this may pertain to breast cancer survivors, it may also pertain to survivors from pelvic cancers, rectal cancers, bladder cancers, that they may have been too uncomfortable to have sex, okay? There are some gadgets which can be very, very helpful to get back in the swing of things, okay, to make you ready to have sex. And one of these, okay, a whole group of these are called vaginal dilators, dilators, okay. And what a dilator does, it's a very simple concept. It's like a little cylinder, okay, and it has a certain length and a certain circumference. And the dilators go up in size. Okay, they start with very tiny and then a little bigger and a little bigger and a little bigger until they come to the really large varieties. Okay, and when I put the set out to show my patients, I say, and I don't know your partner, what size he is or what size toys you like to use, but you tell me and we'll find the right dilator size for you. But we oftentimes, if somebody hasn't had sex for a while and are pretty uncomfortable, we'll start with a small one. And basically you pop it in the vagina using a lubricant so it doesn't hurt. Okay, and then you keep going up, manipulating these things around 5-10 minutes at night, wash it off with a little soap and water, and then the next night or 2 nights later or whatever, watch a little TV or whatever you'd like to do to entertain you while you're doing it, 5-10 minutes with a dilator, and just keep stretching. Okay. The brand, again, there are tons of brands out there on dilators. The cheapest brand, believe it or not, has a really stupid name. It's called vaginismus.com. Okay. Vaginismus is something that can be treated. It's the cheapest and most efficient set of dilators. The one I tend to like a lot is something called Soul Source, SOULSOURCE. And these are, again, online. You don't need any prescriptions. A lot of this stuff, there's no medical intervention necessary. These are things you can do on your own. Okay. But of course, we're always here to help if you need some help. Okay. And that you can, and there's, so if you go to soulsource.com, you can see the product, you can order the product online. Okay. And again, use it with some lubricant. And you can also, if you're using estrogen cream, use a little estrogen cream around. That helps stretch things. Okay. And just keep playing with it. And on the Soul Source website, there were a bunch of videos on how exactly to use the dilators. So they'll give you some guidance. You're saying, I don't know what I'm going to do with these things. Go to soulsource.com. Even if you don't have a Soul Source dilator, it's fine. You can go to soulsource.com, get a whole bunch of dilators, okay? And that you can play with these things, and they will get you to be able to have sex, okay? That almost everybody can. So that these are really good. You get some moisture going in the vagina, you got some dilators to help stretch, and you'll be in business, okay? Couple of other things that you can do, okay? Because we want to think there's many, many, many tricks that we can do. Okay, so I don't want to get to, intimacy being difficult and being impossible. No, we can make this happen. Okay. That another trick that we can do, and I always get people nervous when I start introducing this, and I'll say, when you go to the dentist, they usually give you some Novocaine, don't you? Well, don't they? And people get all nervous and they say, oh my God, she's going to give me a shot. This is awful. And the answer is no. Okay. Remember, before the dentist gives you a shot, she or he rubs a little Novocaine jelly on the area so it won't hurt when they give you the shot. Well, guess what you can do for the vagina? You can do the same thing. You can take some estrogen, you can take some Novocaine jelly, and that's what we use is Novocaine jelly, and you rub it around the opening of the vagina. If somebody hasn't had sex for a while, they're anxious about it, and we can numb up that area very quickly. Like at the dentist, it takes 3-4 minutes to numb that area. Basically, it'll take 3-4 minutes at most to numb that area around the opening to the vagina. Will you still have pleasure? Yes. Will your partner still have pleasure? Yes. Will he get some of it on his penis? Yes, he might. Is it going to numb him? No, he's not going to suffer. Don't worry. And the other thing is, if you try it and you don't like it, it's going to last for 45 minutes or so. So it'll be gone. Okay. It's not something that's going to permanently injure you if you're thinking about doing it. Okay. So we can always get you some the Novocaine jelly. It's very helpful. And again, and if you have one other thing though, if you have sex more than once that evening, since it only lasts about 45 minutes, you may want to reapply some more if you need some more to help sex be more comfortable for you. So those are little tricks that we do that can be very, very helpful to get people back into a sexual life. Okay. And all of those are, and again, you don't have to use estrogen cream. We have non-hormonal moisturizers. Novocaine has really essentially no toxicity. So these are all things that can be really, really very helpful for people. And again, not just people with breast cancer, people with any cancer, if they've had radiation therapy to the pelvis for certain, for a GYN cancer, they've had rectal cancer, they've had bladder cancer. We have a number of people with those, and they do very, very well with this approach to restoring their normal sex life. Okay. Now, there is one other mechanical thing that we use, and this is very interesting, I think, that some women, unfortunately, not so much that we see this with breast cancer, but we see it sometimes with people who had radiation therapy for rectal cancers or for bladder cancers, things like that, that the vagina itself gets to be a little shortened. Okay. And that can happen. Okay. It can happen with some gynecological cancers as well. Okay. And so and you say, gee, it's really hard. My vagina is fairly short. We have something for that too. Okay. And this basically, it's a very funny name that this product has. And it's called OH-NUT. It's the O-nut. Okay. And what the O-nut is basically 4 very soft rubber rings that attach to each other. Okay. So it looks like a kid's toy when you see it. Honestly, it does. But what you can do with these bumpers is that if you find that your vagina is short and your gynecologist or oncologist who's checking you, whatever, says, the vagina's a little on the short side, What these bumpers do is they can be put on an erect penis, okay? And they act like bumpers so that if it's a male partner penetrates, okay, he won't be going in as far as he would normally because those bumpers there's a sense that there's something there, but he's not penetrating into the vagina totally, okay? It feels like to the partner, to the woman and to the guy, presuming it's a heterosexual couple, they will both feel like they're having regular intercourse, but it really helps protect from too deep penetration and making women uncomfortable. And it really can be a great gadget, again, particularly for the people with pelvic cancers, pelvic radiation. That can be very, very helpful for them. Okay. So we got a lot of gadgets which are really very, very helpful for people. Okay. And there's no reason we can't get you sexually comfortable. There really isn't. We can just do that for just about everybody, honestly. Okay. Terrific. Do we have some more questions here? We must have more questions. Okay. Okay. Let's keep going down here. Do I have any more specific questions? Okay, let me talk about other general things. Okay. Let's talk about estrogen therapy in general, okay, and not vaginal estrogen therapy. Let's talk about systemic estrogen therapy. What can we do for women who go into menopause, okay, and maybe early because of chemotherapy or radiation therapy, things like that, and they go through menopause? Do we have the concerns that we have about estrogen for everybody? And the answer is no, okay, that breast cancer, of course, seems to be, there are estrogen receptor positive tumors, of course, and that brings up the concern about treating women with estrogen therapy. The vast majority of cancers that are out in the world are not sensitive to estrogen. Okay. And that goes along for cancers of the renal tract, most gut cancers, lung cancer in general, hematological cancers, Hodgkin's disease, lymphomas. Many of these women can take estrogen without a problem at all, okay? And particularly, let me look at one that's really specific for my business, which are the cervical cancers, okay? Cervical cancers tend to hit, unfortunately, younger women, okay? I don't want them hitting anybody, but unfortunately, the younger women are more or seem to have more of an incidence of cervical cancers. And if a woman who's going to has her ovaries out as part of the therapy, or she receives radiation therapy as part of her therapy and becomes menopausal, you have these women who are very, very young, 35-year-olds, 40-year-olds, who are becoming menopausal, okay? And cervical cancer has nothing to do, in general, there are a very couple rare exceptions, but the vast majority of cervical cancer doesn't care whether there's estrogen around or not, okay? So if you have somebody who's 35 years old, who's a very young woman, obviously, and she's undergoing menopause, okay, that's not so good, because it's not so good because she's going to feel bad with heart and, she's going to feel bad because she's going to have hot flashes and night sweats, and she may not sleep at night, all those fabulous things. But she also, if she's losing her ovarian function, is going to be at a higher risk for getting heart disease. Women who experience menopause early in life, certainly way before their 45th birthday, for example, even some people would argue before their 50th birthday, but young women who become menopausal do seem to have an increased risk of heart disease, of bone loss, osteoporosis, and many people would also say dementia. Those are the risks of undergoing menopause too early, okay? And so from the women who have cervical cancer, they are great candidates to get estrogen replacement therapy. We don't want them getting those medical issues, and we also don't want them getting hot flashes, and we also want them to have good vaginas so they can have sex, and that's important. So that estrogen tends to be very, very favorable in an equation of saying who should take it or who shouldn't take it. Those are people who would really, really, really benefit by estrogen therapy. Another group of people that sort of relates to gynecological cancers is, and we are seeing more of these people, and we call them, it's a term that some people use, some people don't know about it. If you have a woman who finds out that she has a BRCA gene, her mom had breast cancer, or grandma and mom had breast cancer, something like that, and they had their genetic testing done, and she finds out that she too carries the gene, and she's young, she's say a 35-year-old woman, that if she's had her babies at this point, and says, okay, I'm done, that we will recommend in general, depends on the particulars of the situation, but certainly 35 to 45, we will recommend that she has her ovaries taken out so that she doesn't end up with a BRCA positive, with a BRCA related tumor. And these are obviously very young women who were taking out their ovaries. And it is a significant recommendation that if a woman who is BRCA positive, has not had cancer, and we are taking out her ovaries, which is what we recommend, that indeed she be given estrogen therapy. There's no reason she can't. It does not increase her risk of getting a subsequent breast cancer. Okay, so having the surgery was still a very good idea for her as far as diminishing her chances, but also it's a very good idea because it'll take out her ovaries and she won't get ovarian cancer, which is a good thing. I mean, some people get a peritoneal cancer, but that's rare. So these are all very good things for what happens to our patients, that they have their ovaries taken out, and we can safely give estrogen replacement therapy to almost all these women. And it's good because they'll be comfortable, they won't be miserable with hot flashes, and we'll be protecting them from getting particularly osteoporosis, heart disease, and dementia, which are the things that we really don't want these young women getting. Okay. And if we do have any BRCA people who are listening right now, what I am going to tell you, stay tuned. You'll be getting in your mailbox, I am sure, a notification that Joanna Didario, who I mentioned to you early, who sort of really runs our SIMS program, is putting on an annual event that she does for people who are BRCA carriers, to learn more about their gene and their genetics, and also to talk about medical issues and way we can help them to try to prevent some of the medical issues that they might be dealing with. Okay, so those are all people who are candidates to get estrogen, even if, people say, oh, but it's gynecological or it's related to breast. No. These people are quite legitimate in taking estrogen therapy, and it will be very helpful for them. Okay. Do we have any more questions in the chat here? Let's see. Nobody else has any more questions, and I'll just keep going. As far as different cancers that are out there. So anyway, there is another group of people who we really do recommend estrogen in certain forms. Okay. And if I have any bone marrow transplant survivors out there, okay, fortunately with bone marrow transplant technology, we've done beautiful things for many of these women. Okay, we got this. Perfect. I'll answer the question. Thank you. But women who who need bone marrow transplants, that if somebody develops something called graft versus host disease, okay, and we don't know why, but women who have had bone marrow transplants and end up with graft versus host disease, okay, that this actually, for some peculiar reason, doesn't have to, but can cause scarring at the top of the vagina. And we don't know why. We really don't know why, but it does occur. And the good news is, if you go looking for it and you find the scar, you can break up the scar tissue. Okay, so that any woman who has graft versus host disease after a bone marrow transplant should be seeing her gynecologist regularly. If she doesn't have a gynecologist, have one recommended by the oncology team, because she needs to have an annual pelvic exam to see what's going on in her pelvis, which sounds crazy. What's going on in her pelvis regarding graft versus host disease? Well, guess what? It goes there. And the other important thing is, many of these women who have had various leukemias and lymphomas, things like that, and end up with a bone marrow transplant, they also end up going through menopause. And some of them are very, very young. We had a young woman a couple of weeks ago who had, about 3-4 weeks ago, who had a bone marrow transplant. And she was fully menopausal at the age of 37, which is a kid. And so we talked to her, and, she fortunately did not have any scarring at the vagina, which was very good. But we talked to her extensively about going on hormone replacement therapy, and she was very amenable to it. She had done some reading about it also. So anyway, those are people that you wouldn't think of having gynecology problems, but they do, and they really need to be seeing a gynecologist regularly. And of course, most gynecologists can handle a lot of this stuff. Now, I see the question here, okay, if we want or need more support, how to get in touch with the team at the center you work at. Well, the team that I work at is at Yale, or I refer to it as the mothership. So anyway, we're at Yale. We're called the Sexuality, Intimacy, and Menopause for Cancer Survivors program. And whoever you see, if you're in the system, they can put in a referral to see us, okay? And we will, we'll get you in and get get you evaluated, meet with the medical folks, meet with the psychology behavioral health team, and try to come up with a program for you that will help deal with whatever kind of issues you're dealing with related in the sexuality, intimacy, and menopause situations. And so they can put in a referral. The other people, of course, that we work closely with are the survivorship team, okay, because the survivorship team deals with all aspects of survivorship. We're obviously focusing on a small area of it, but we do have we do have access to excellent psychologists who really help our patients, I think, a lot. So anyway, so yeah, your provider can put your reference into the SIMS program at Yale. And unfortunately, I will say we are backed out a bit, but we'll get you in and get you evaluated and try to get everything taken care of. Okay. And I think we do a reasonable job and get most people feeling better. And whether you're a candidate for estrogen or not, we can. And the other thing that I should mention now, speaking of candidates who are not for estrogen, because some of our breast cancer survivors, are young and they are menopausal, and they really, or they had been on estrogen for menopausal symptoms, and now their oncologist says, well, you have an estrogen receptor positive tumor, so we really don't want to give you too much more estrogen, understandably. But you're having miserable hot flashes. You're having really terrible hot flashes and night sweats, and your sleep's awful. And we hear from so many women who are dealing with those issues. We used to have medications for them that worked. They weren't bad. For example, as far as hot flashes that are non-hormonal therapies, something that most people don't realize is that SSRI and SNRI antidepressants can actually be very helpful for hot flashes. So can that magic medicine called gabapentin, which everybody takes. I mean, it's for everything, including the common cold, as I say. No, it is not. But anyway, gabapentin can actually help with hot flashes. There are some herbs that, even though the North American Menopause Society, now known as the Menopause Society, says, oh, these herbs don't work. There are some that do. There are some that don't. Not all herbs help everything. We tend to use it on a couple of herbal products that we like a lot. There's a product called Remifemin Good Night, which is Remifemin is German black cohosh, and which you can get at CVS or Walmart. It's over the counter. It's not a prescription medication. So you can certainly use Remifemin in just about every situation. However, the Remifemin Good Night is a product we like a lot because, again, many women do have problems with sleep. And the Good Night component is basically it's some valerian, some lemon balm, some hops. I say, of course, because it's a German product. But anyway, but it is quite good for many women for sleep and for hot flashes. So we use it pretty regularly, and you get that on Amazon. Most pharmacies don't stock it, although occasionally you'll find one that does, but Amazon should have it regularly, and you can use that. So that's another product that we can use for hot flashes. And there's a new herbal product out. See, I'm driving you crazy with all these different options. But there is a new herbal product out, and it's called Thermella, Thermella. And it's related to a drug that I'm going to be talking about in a minute, but it's just sort of like the junior version. It's an herbal knockoff in a sense, okay? And the new drugs that are out there, which really are much better than, as far as efficacy, than gabapentin and certain SSRIs, which do help. Don't get me wrong, they do help. But this medication is currently out now. It's called fezolinetant. Or its trade name is Veozah, Veozah. There are several drugs that are in development. There's one that's fairly close that's probably going to be out in 2025. So we'll get another 6 months, and we'll probably have a choice of these medications out there. Right now, there's just one. And this is a medication that you take every day, okay? It's called Veozah or fezolinetant. And it's pretty well tolerated, and it knocks down hot flashes. It is not going to help your vagina. It's not going to help your achy joints. Okay, it's not going to help any of that stuff. Well, the Thermella might. It's designed to do that as well, but the Veozah does not. Okay, and you have to take something else with it for these other symptomatologies. Okay, but the Veozah definitely will help with your hot flashes, and it's a pretty good drug. Only major side effect that it's associated with are some questions on liver enzyme functions, which are unusual, but they can be there. So you have to have liver functions test pretty regularly, but that's not the end of the world. It can be done. So those things are there and can be done. And it works very nicely. The other nice thing about the Veozah is it works very quickly. Okay. So we have had patients who are comfortable within a week, and somebody who's been sitting up there with hot flashes and night sweats for several months or several years now is going to say, How come I don't know about this stuff? Well, it's available now and it does help with hot flashes a lot. So, and it's non-estrogenic. So you guys can take it. And fortunately, again, there are another couple of these drugs coming out. Okay, so these are how you take care of the hot flashes, but we have many, many options, and people shouldn't think they have to suffer with these things. It's not something that has to be suffered with. Okay, any more questions here? Okay, oh, just a note about basically, yeah, the names that we're going to have this, you're going to get the link to this. So you'll hear it again and you'll know when we spell it out what drugs you might be interested in or what products you might be interested in. Okay. So these are all options that one can take and can be helpful. Okay. And so we have many, many different ones, many with, some of the little different side effects, but we can help pretty much everything these days. Okay. We've got hormonal products for the vagina, non-hormonal products for the vagina. We've got hormonal therapy for hot flashes. We've got non-hormonal therapy for hot flashes. We got herbal products for all this stuff. We have a wide range of options that are out there. Okay. Now, the other thing I know that some people are going to be watching this, and I get this question fairly regularly from people all over the country asking me, well, how do I get some help? I'm in the Yale catchment area. I don't, can't come to see you guys there. And by the way, we do telehealth for people. So if people can't come into the hospital to the mothership at Yale, we do telehealth visits. So that can be arranged. It's not impossible. If they can't do a pelvic though, it's hard to do the pelvic exam if we're not in the same room. We could think about it, but we really can't. But that's another story. But anyway, so there are these different options that are out there. That we can do, and that can be very, very helpful. And we've got something for everybody, really, as far as these different options that can be quite helpful for folks. Okay. Anybody else with some questions here? Okay. Nobody else has any questions. All right, well, come on. I'll keep talking about different products that are out there that might help everybody, which is what we're hoping for. Okay. As far as, are there other things that we can do for bone health and things like that? Okay. And the answer is yes. Okay. One of the concerns that women do have, and this, it may not come under the line of sexual health, but it comes under the side of menopause issues. One of the things, of course, that can unfortunately contribute to be side effects related to menopause, of course, is bone loss. And I know all of your oncologists are on top of that and discuss with you getting bone densities, particularly if you're on an aromatase inhibitor or something like that, which really lowers your estrogen level so that you're at higher risk for bone loss. Okay. Several things to make sure you don't experience bone loss, and we recommend this to all our patients. We basically encourage people to get some calcium on board. We encourage it, if possible, to get it from dietary sources. Okay. The calcium, of course, is in many foods, not a ton of foods, but many foods. It's in dairy products, particularly milk, yogurt, cheese, ice cream. Think of all those calories, but think of all that good calcium. And that's there. As far as vegetables, broccoli and kale are your best vegetables for calcium. Okay. The other thing that nobody eats is sardines with bones, but that's good for calcium too. But unfortunately, many people think like, oh, it's a green vegetable, it's good for bones. Not really. Spinach is okay, not great. Lettuce does not very much at all. So don't go eat a head of lettuce. Unless you really want to help your intestines or something, but it probably won't help your bones all that much. But getting in some calcium-rich food is helpful. Calcium supplements can be helpful if you don't get much intake in your calcium levels. Almost everybody needs some vitamin D. We don't live in the South, and even people live in the South, I don't know how much they go out these days. So sunshine's good for your bones, but if you're not, in the deep South, like you're in New Haven, please start taking some vitamin D if you haven't been already. Little tiny guys, these 1,000 to 2,000 unit pills will help. Some people will say just automatically take 5,000. You're getting plenty at that level. But we have these different levels and stuff, but you want to be taking some vitamin D. And the other thing that I can't emphasize enough is move. Move as best you can. Moving is great, okay? And it's good for bone strengthening. It's good for muscle strengthening. These are phenomenon of the fact that many of us are not dealing with a total load of estrogen because chemotherapy or radiation therapy has helped knock it out of us, okay? But exercise is good. Now, I hesitate to say this, I always hate to say the statement, swimming is not good for you. Swimming is fabulous for you. It's terrific cardiac exercise. It's really wonderful. Unfortunately, swimming will not help build your bones. okay, or keep your bones from losing calcium. So if you do swimming and you have a passion for it, that's fabulous, but you also want to get some strength training in. And a source that I like a lot for strength training, I mean, going to the gym is great and working out with the trainer is terrific, and doing your other exercises and yoga, all that stuff is excellent. But one thing that I do encourage people to do is some strength training. And there's a very good guide out for strength training that I will mention to you all. Let me just grab a sip of moisture here. The book that I would suggest to all of you is actually, I'm going to start with this woman's website. The woman's name is Dr. Miriam Nelson. She is a professor of exercise physiology, and she was at Tufts for a number of years. I think she's now retired, but her website is called strongwomen.com. And she's got strong women, basically everything, strong bones, etc. And exercise is good for most things. So basically, if you go to her strongwomen.com website, she's got plenty of exercises right there for you to do at home. Not that you'd have to go to a gym and get an elaborate set of equipment, stuff like that, but that will very much help your bones. And they're very good. Her book, Strong Women, Strong Bones, is terrific. And she does have DVDs that go out with these so that you can basically, some people like to watch somebody exercising. So if you're one of those folks, you can get the DVD and exercise along with Dr. Nelson. She's really good. And she's a very knowledgeable person. And one of the other concepts that people are talking about these days, in addition to osteopenia, is sarcopenia. Sarco means muscles. And so when you're not doing a lot of strength training exercise, that you are at risk of muscle mass loss as well as bone loss. Okay. So that exercising is very good for prevention of muscle loss, sarcopenia, and protection of bone loss. So if you say, what can I do to help protect myself from osteoporosis? I mean, yes, taking estrogen will help protect. It does not rebuild bone, but it's good at helping protect it. That's fine. If your cancer is okay with estrogen, therapy, that's fabulous. If it's one of those like a particular gynecological cancer or a particular breast cancer that people discourage it, maybe you might not want to be taking it. Okay. So those are things to keep in mind. Okay. The other issues, of course, that we mentioned is that we want to protect the heart. Okay. Protecting the heart is just as important as protecting the bone, I think. And exercise there is terrific. And that's where your swimming comes in great. Okay. Swimming is fabulous cardio exercise, and running, walking, anything, moving is excellent for cardiovascular health. So, and again, it's tough having cancer. There's no question about it, but you don't want to sacrifice your heart as far as not doing exercises and protecting it. So, doing exercises are great, and you want to do a combination, ideally long-term, of both aerobic and strength training type stuff. It's very good to do both. And I must confess, and this is true confessions time, I love doing aerobic exercise. I love to run. I was the world's slowest runner, but I love to run and swim and stuff like that. And unfortunately, I was not doing that much for my bone mass. Drinking my milk that's a good thing too. But anyway, and it wasn't until about 16 years ago, I count the day that I started doing some strength training, and it was fabulous. It was one of the best things that ever happened to me. You have a better sense of well-being when you throw in some of that strength training. Strength training with your aerobic exercises. Strength training is just fabulous that way. So keep doing it. If you're doing it, keep going. If you haven't tried it, give it a try. Maybe go to the gym with one of your buddies and start doing it. But I will warn you, it's addictive. But that's a good addiction. That's fine. Okay. So anyway, so those are things that you want to do. And of course, the other thing that people talk about as far as what am I going to do if I'm in early menopause compared to being in, menopause later on in life. And brain exercising is good. I wish I had as direct things to say, get some vitamins and calcium in and stuff like that. But you want to maintain a happy diet. You want to be getting your vitamins in. You want to get your calcium in. You want to get your vitamin D in, your important stuff. You don't need all sorts of fancy super vites and people getting these different panels and stuff like that. Most of that stuff is sort of, you really don't need it. But certainly your vitamin D is good, and exercising, doing strength training is really, really wonderful for you. So I would encourage everybody to be out there doing it, cancer or not, that you want to be doing it no matter what. Okay. Other folks, anybody else have any other questions? I want to make sure if there's something pressing here, that I want to make sure that, you don't come out and say, oh, she didn't talk about that. I want to talk about stuff you need to know about. Anybody else with any questions as far as health maintenance, as far as sexual issues, things like that? Okay. All righty. Well, I am going to close a little bit because we still have a little bit of time. That there are some issues that we hear pretty regularly, okay, in our program. And one of the issues that we hear as much as anything else out there, I won't say necessarily the most common problem, and it does sort of relate to the vaginal dryness issue, which many, many, many people have. And I hope, my suggestions will be helpful for many of you to be using. But one of the major concerns that many women experience, and this is multifaceted, is the loss of libido. And that can be a major problem. It can be a problem for women, as far as not even if they have sexual difficulties, as far as dryness or discomfort, just they've been in therapy, they've been doing, they've had some surgery done, they feel that they're not comfortable, they're not getting back to their normal baseline of activities, things like that. And there are many things that can lead to decreases in libido. And again, we try to help with those things too, okay? And our behavioral health folks can be very helpful there, because what they will talk about are things like communication skills, that communication is really important, okay? And the other thing that I talk about regularly is I'll maybe conclude with some of her words for you. And I guess I've had a couple of losses this year, including my dear teacher, Peter Schwartz. But somebody who I was a very lucky person. I had the privilege of working with Dr. Ruth Westheimer. And Dr. Ruth had several words of wisdom about libido. And I will pass them on to you because unfortunately she's no longer with us to share her wisdom with us, but she passed it on to me and I'll pass it on to you. So Dr. Ruth had a few sayings regarding libido. One of her favorite sayings was the most important, and I will do it in her accent because her accent was so charming. The most important organ for sex is not between the knees and the shoulders. It is above the shoulders. And Dr. Ruth always believed that that issues in emotions and sexual issues arose really as far as they were not related to our pelvis. You didn't have to have a fancy pelvis working to have libido. Okay. And Dr. Ruth's other wise thing that she always said, if it's between two consenting adults, it's fine. If it's between animals and kids, no. But if it's between two consenting adults, it's fine. So anything you guys think of, if it's fine for two people, that's terrific. Dr. Ruth will be blessing you from heaven, which is where I'm sure she is right now. Okay. So that's something else from Dr. Ruth. Okay. And the other thing that I will pass on to you from Dr. Ruth's words of wisdom is that she was, again, getting back to the idea that the sex organ is really above the head. It's above the shoulders. It's really in the head, and it's relationship issues much of the time. And let's face it, if dealing with cancer, it may very much have an effect on the relationship. And that's part of the reason we love having our behavioral health team with us, that they can suggest ways that you can communicate better with your partner and talk about sexual issues in a more candid and frank way that you might not have felt totally comfortable with. So that's part of the reason we have our team together. Okay. But Dr. Ruth, in her talking about communication skills, which is what she always felt, and she would say and this was then the people we were talking to on this tour that we went on together were just plain regular lay audiences. I mean, obviously we had some cancer survivors in the group, but Dr. Ruth would always say, and this is in the post-Viagra era, and she would say, she said, the guy goes, he takes this pill, this blue pill, and she says, and he has an erection that goes from the floor to the ceiling. And he says to you, come here, honey. And you say, what? And he hasn't taken out the garbage in a week. This is verbatim, Dr. Ruth. And if there's a sporting event on, God forbid, you're not going to see him at all. Forget that. Okay. And he says, come here, honey. You're not interested in that. Okay. So that's not the way to have sex. And so the Viagra is not really a libido pill. And the little blue pill that she would jump on. Now it's useful in certain circumstances, of course. Now, unfortunately, we don't have a pill like that for, and Viagra is not a libido pill, by the way. We do have some things that can help with libido. I mentioned the Rostella originally. That's something that anybody can use. But we can work on helping with communication skills and getting the couple together again and talking about interventions that can be helpful. And there are some other things that we can talk about for orgasms in women, although it's not a libido pill. There are sometimes occasionally where Viagra can be used in women, but we will say stay tuned and come visit us if you want to talk about these things. It's not regularly prescribed, but it is something that we can say. Okay, so I just wanted to give you a tour of what kinds of things we deal with, and these are the things we deal with every session that we have of our Sexuality, Intimacy, and Menopause for Cancer Survivors program. And if you're having an issue, we hope you don't have any issues. We hope you're absolutely just fine, but these issues do occur. The other thing that I'm going to ask you all to do, as far as information sources, okay, is my website is called madameovary.org. It's newly revamped. And I have and you press the podcast button, go to madameovary.org, press the podcast button, and you will see 30 podcasts coming up, not videos, podcasts. And about half of them have to do with menopause and some do with sexuality. And they might be of interest to you. So anyway, so they're there for you. And we do have one, I actually have a couple of podcasts on sexuality, intimacy, and menopause issues for cancer survivors. So I have a couple of podcasts there dealing more in detail with these particular issues if you are dealing with them. Okay. And I think we have tomorrow night, I guess, is the next Smilow shares. Of course, we're in the month of October here. Breast cancer awareness, Smilow Cancer Hospital, Trumbull. And you have the code there to get you on. Okay. So I want to thank everybody who's here for joining. And I hope that some of this information was helpful for you. And obviously, hope again, please go visit madameovary.org and see if you have some more questions answered. And I hope that we may be able to be of assistance. Okay. So can I turn the floor back over to Eliza? Any further comments from you, Eliza?
All set. Thanks again.
Okay. Well, thank you all very much for joining in. Thanks a lot.